Good evening to all. Welcome to Rayos125, the online academic programs organized by ISRT Kerala chapter. I am Veena RR from Regional Cancer Center Trivandrum, and my session is about stereotactic roundtable breast biopsy. A stereotactic breast biopsy is a procedure that uses mammography to precisely identify and biopsy an abnormality within the breast. It's normally done when the radiologist sees a suspicious abnormality on your mammogram that can't be felt in a physical examination. The development and widespread use of percutaneous image-guided breast biopsies has expanded the role of breast imaging and changed the management of breast diseases. Validation of the safety, accuracy, and cost effectiveness of these biopsies has led to the replacement of surgical biopsy for most of the lesions which requires a tissue diagnosis. High false positive rate of mammogram, especially of dense breast, demands additional evaluation. Stereotactic breast biopsy has increasingly been used as an alternative to surgical biopsy of suspicious breast masses. Stereotactic core biopsy make use of the principle of parallax to determine the depth or Z dimension of the target lesion, and it pinpoint the exact location of the breast abnormality by accurate quantitative computer localization in 3 dimensions, that is in X, Y, and Z axis. The depth of the lesion or the Z-axis coordinate is determined by calculating the parallax shift, that is, apparent shift of the target on the stereo images. The stereo images are taken at plus 15 degree and minus 15 degree, and the images are compared with the target location on the reference image or scout image. The distance of apparent lesion shift between images can be used to calculate the depth or Z dimension. The location of the center of rotation of the stereotactic biopsy system must be known to understand the significance of the apparent motion in the lesion. In this image, we can see a reference image or scout image and 2 stereo images which are taken at plus 15 degree and minus 15 degree, and can see the lesion shift in the stereo images. Basically, 2 types of stereotactic biopsy systems are there. One is Fisher system and other is Lorad system. In the Fisher system, the center of rotation is in the compression plate, it's here, and with the Lorad system, the center of rotation is in the imaging phosphor. So that with the Fisher system, the parallax shift increases as the lesion is located more superficially, and with the Lorad system, the parallax shift increases with increasing lesion depth. This difference results from the different placement of the center of rotation of the 2 units. Next is the technical prerequisite. The breast compression must be 5 mm or greater than the depth calculated, that is Z dimension calculated by the system. The procedure can be performed only if there is adequate stroke margin. Now you can see what is stroke. Stroke is the distance that the needle moves from the cocked position to the fired position. Here we can see the needle tip in the cocked position, and in the fired position it will reach here. So this distance is a stroke. And stroke margin is the distance from the tip of the needle in the fired position to the image receptor. So in the fired position, the needle tip will be here, and the distance from here to the image receptor is called the stroke margin. The biopsy can be performed only if there is adequate stroke margin. What is negative stroke margin? A patient with thin or small breast may not have adequate stroke margin. Here we can see there is no adequate stroke margin, And in such cases, if the biopsy is performed, the needle will pass through the entire breast and will strike on the image receptor. Here, the needle is striking the image receptor. This is called a negative stroke margin. Positive stroke margin indicates that there is adequate stroke margin to perform the biopsy. In this picture, we can see a safe stroke margin. What are the indications for doing stereotactic brown table biopsy? One of the indication is the presence of suspicious solid masses, which are seen only or more conspicuously on mammograms. It may include masses, asymmetries, or architectural distortions which are not identified at the ultrasound. Another indication is the presence of microcalcifications. Microcalcification is tiny cluster of small calcium deposits. Another indication is the presence of new mass or area of calcium deposits at the previous surgery site. Next is planning. For planning, routine mammograms are taken. From the routine mammogram, the position of the patient and approach of the procedure is decided. Next is equipment. A dedicated prone-table stereotactic biopsy unit comprises of a prone biopsy table. This is the table and it has an opening here for positioning the breast. There is a mammographic CM X-ray system. This is a CM system with an X-ray tube here and a receptor, image receptor here, and a biopsy performing stage. This is a biopsy performing stage and gun needle combination for performing biopsy and a computer system. The needle sizes used for biopsy are a 14 gauge cutting needle, 16 gauge needle and 18 gauge needle, in which 14 gauge needle is having more accuracy. Next, patient positioning and approach. The patient lies face down with her breast projecting through the hole in the table. The actual biopsy is done below the table after raising the table to appropriate height. A paddle-shaped instrument with biopsy window compresses the breast during biopsy. This is a paddle and it has a biopsy window for performing the biopsy. Next is the procedure. First of all, a scout view is taken to include the lesion within the biopsy window. Then a pair of images are obtained, stereo images are obtained after moving the X-ray tube and detector assembly to plus 15 degree and minus 15 degree relative to the zero position on the scout image. Then the targets are marked in the stereo images. Here we can see the targets marked in the images and the computer will generate X, Y and Z coordinates for each target. Once the coordinates are generated, they are transferred to the stereotactic table. Using these computer-generated coordinates, radiologist inserts the needle and advances to the location of abnormality. Then pre-fire images are obtained to confirm that the needle tip is within the lesion. Then the radiologist performs the biopsy and post-fired stereo images are also taken to ensure that the lesion could be successfully sampled. Sometimes a tissue marker is inserted in the biopsy site in case of removal of target and to facilitate the follow-up on subsequent mammograms. The marker is made up of titanium and another image is taken to confirm the position of the marker. After performing the biopsy, the specimen radiography will be performed for all lesions with calcification, since a specific histological diagnosis is more likely to be obtained if calcification is present in the specimen. Conclusion. The stereotactic biopsy procedure is usually fast, relatively pain-free, and similar in accuracy to more invasive surgical biopsy. Next is the advantages. One of the important advantages is that the tissue diagnosis is obtained without surgical biopsy. And there is no recovery time for the procedure. Compared to the surgical biopsy, there is no cosmetic scarring. And it is an excellent way to evaluate calcium deposits or tiny masses that are not visible on ultrasound. Next is limitations. A number of potential problems can occur with the stereotactic prone biopsy. This include negative stroke margin in case of thin breast. The same problem arises in the patients with the lesions that lies close to the distal skin surface. There are a number of approaches to remedy the negative stroke margin. The planned approach can be changed and the breast positioned in the orthogonal position. The location of the lesion related to the skin surface may change sufficiently to allow the safe insertion of the needle. In case of lesions which are close to the chest wall or high in the axillary tail of the breast, it will be difficult to sample using the prone stereotactic technique. In such cases, by rolling the patient toward the table aperture and passing the arm and shoulder through the opening, more of the posterior and axillary tissues can be brought into the biopsy window. Thank you. And I once again thank the organizing members for providing me an opportunity to be a part of the 125th anniversary celebrations of discovery of X-rays. And I congratulate each and everyone who took part in organizing this academic event. Thank you.